Hi, everyone. My name is Chris Palmer. I'm going to be speaking with you today about metabolism, mental disorders, and the ketogenic diet. In order to get started, I just want to list my disclosures. The only disclosure I now have is that I am the author of a book, Brain Energy, that will be published later this year. But otherwise, I have no financial relationships whatsoever to any companies or anything related to the ketogenic diet. So I want to start by talking about this connection between what we call mental disorders and metabolic disorders. It turns out that mental disorders have strong bidirectional relationships with all of these metabolic disorders, things like obesity, diabetes, cardiovascular disease, and Alzheimer's disease. Although most people don't think of Alzheimer's disease as a metabolic disorder, by the end of this presentation, I hope you might. And what do I mean by bidirectional relationships? I mean that if you look at people with mental disorders, they are much more likely to develop all of the disorders on the right-hand side of the slide. But if you look at any group of people who have any one of the other conditions like obesity, diabetes, cardiovascular disease, or Alzheimer's disease, they are much more likely to have mental disorders or at least symptoms of mental disorders. I'll walk you through a little bit of that literature. So obesity and mental illness have strong bidirectional relationships. People with major depression are 20% more likely to be obese, but people with more serious mental disorders like schizophrenia and bipolar disorder, it has long been known that they are more likely to develop obesity. One study followed patients for 20 years. Nearly 2/3 of the patients with schizophrenia and over half of those with bipolar disorder became obese. Individuals with a higher BMI actually exhibit alterations in brain circuit connectivity, which is something that is found in a lot of people with mental disorders. Obesity itself leads to higher rates of mental illness. This large series found that obese patients were 25% more likely to have a mood or anxiety disorders. And patients, when followed for 10 years or more, researchers have found that diets that are high in junk food lead to higher rates of obesity, not surprising, but also higher rates of depression. It turns out that obesity actually worsens the course of bipolar disorder and also depression. So although this slide looks like a treatment study, they actually just separated bipolar patients by whether they were obese or not. And the patients who were obese had more depressive episodes over time. So obesity is actually playing a role in the mood symptoms of bipolar disorder. Likewise for chronic depression. What about diabetes? Again, strong bidirectional relationships, and in many ways, this is nothing new. The connection between diabetes and mental illness has been known since the 1800s. People diagnosed with schizophrenia are 3 times more likely to have diabetes. People with depression are 60% more likely. It turns out that even when people come in with schizophrenia or bipolar disorder, before we give them one pill, they already show signs of glucose dysregulation. So a lot of people assume that the reason the mentally ill become obese and develop diabetes is because of the pills that we're giving them. There's no doubt that the pills we're giving them make a difference, but it's more than that. What if we look at it the other way around, people with diabetes? Well, it turns out if I go to a diabetes clinic, on average, I'm going to see about twice the rate of clinical depression. But when people with diabetes develop depression, it lasts 4 times longer. So at any given time, actually about 25% of people with diabetes have clinical depression. So I want to correct what I just said. If I go to a diabetes clinic, I'm actually going to see about 3 times the rate of diabetes as in the general population, because even though patients with diabetes are twice as likely to develop it, it lasts a lot longer. But the mental affects the metabolic condition. So if you have somebody with diabetes and they develop depression, their blood sugars actually get worse. They have higher levels of insulin resistance, and they have greater rates of vascular complications. So again, we see strong bidirectional relationships between mental disorders and cardiovascular disease. People with serious mental illness are more likely to have cardiovascular disease, even after controlling for the obesity and diabetes that I've already mentioned. Of course, when we don't control for it, the rates are even higher. Depression itself is a risk factor for having a heart attack. In otherwise healthy people who've never had a heart attack, they are about 50 to 100% more likely to have a heart attack. If I go to a cardiac ward and look at people who have recently had heart attacks, if all of the risk factors in two people are the same, only one is depressed and one is not, the one with depression is about twice as likely to have another heart attack over the next year. If I look at that same ward and I look at patients who've had heart attacks or coronary artery disease, about 20% will have depression, and about 33% of those with congestive heart failure will have depression. This is about 3 to 5 times the rate of depression in the general population. And in fact, the American Heart Association and other American College of Cardiology and other sources now acknowledge that both depression and bipolar disorder are independent risk factors for heart disease. Well, with all of that, it's probably not surprising that people with mental illness die early deaths. It has long been known that people with serious mental disorders die early deaths, depending on what study you look at and what population they're surveying. The lifespan reduction is anywhere from 7 to 30 years. But in fact, recent evidence looking at large population studies of over 7 million people find that people with all mental disorders are more likely to die early deaths. On average, men are losing 10 years of life, women are losing 7 years of life. What are they dying of? Most people think suicide. Well, yes, people with mental illness are more likely to commit suicide, but that's actually not the primary cause of death. Primary cause of death is cardiovascular disease and things like diabetes and cancer and dementia. Why? Why are the mentally ill dying early deaths? Well, it's not that this has gone unnoticed. The World Health Organization in 2016 issued a report, and they talked about factors related to individuals' behavior. So let's blame the victims. They must be eating too much and not exercising enough. Or it might be their medication side effects, as I've mentioned. Or maybe it's a problem with the healthcare system. These patients aren't going to their primary care doctors and following up and getting good care and taking their diabetes meds like they should. If only they would do that, everything would be fine. Or maybe it's societal issues. The people with mental illness are much more likely to be unemployed and be poor. And the reality is unemployed, poor people die early deaths across the board, whether they have a mental illness or not. So maybe it's that. But in reality, this is a pessimistic report because it's either about blame the victim and say that they're just kind of lazy, they're not taking care of themselves, they're not eating a good diet, or they're smoking cigarettes, it's their fault, or just it's factors beyond their control and in reality, everyone's control. I mean, managing poverty and unemployment is a huge task, and we are nowhere close to doing that. But this begs the question, what causes mental illness in the first place? Given all these strong bidirectional relationships, what causes mental illness? At this point, the real answer is no one knows for sure. We only know risk factors. And what are the risk factors? Well, we usually talk about the biopsychosocial model, which says there are biological factors, psychological factors, and social factors that all come together to result in mental illness. Now, this applies to all the mental disorders across the board, things like schizophrenia and bipolar disorder. Psychological and social factors play a role, but it clearly also applies to depression and anxiety. Biological factors clearly play a role, as well as psychological and social factors. So all three factors play a role in all mental disorders. And I've been asking the question for years now, could metabolism play a role? But that begs the question, well, what is metabolism? Although a lot of people like to think about metabolism as a fairly simple thing, like burning calories, metabolism is much more than that. And it's actually much more than metabolic syndrome and the metabolic disorders that I have already described to you. It's more than obesity, cardiovascular disease, and diabetes. A simple definition, it's the process that all living organisms use to convert food into energy or building blocks to maintain or grow cells. And metabolism also includes the management of waste products. In essence, metabolism is a fundamental part of the definition of living organisms. And in fact, metabolism is extraordinarily complicated. This is actually a simpler diagram of metabolism in the human body. The circle is the Krebs citric acid cycle, but metabolism is extraordinarily complicated. It does not boil down to one macronutrient like sugar or one hormone like insulin. It's much, much more than that. So why am I asking the question, could metabolism play a role? In many ways, this is nothing new. I want to stress that. Nothing new, folks. This has been known for, well over 70, 80 years now. Metabolic disturbances in people with mental disorders are well documented. The diagnoses include schizophrenia, bipolar disorder, anxiety disorders, PTSD, chronic depression, and alcohol use disorder. What do I mean when I say metabolic abnormalities? I mean differences or changes in levels of lactate, the ATP to ADP ratio, reactive oxygen species, redox markers, levels of NAD to NADH, levels of inflammation, in particular brain inflammation, levels of cortisol, which is a metabolic hormone, and brain insulin. Insulin is about much more than just diabetes. Insulin affects how the brain functions. I've already mentioned that abnormalities of glucose metabolism are often seen in people with bipolar disorder and schizophrenia, but also depression, Alzheimer's, and mitochondrial dysfunction has been found in many psychiatric disorders. So should we be thinking about the ketogenic diet as a metabolic treatment? So what is a ketogenic diet? I'm assuming a lot of you at this conference know. It's a high-fat, low-carbohydrate, moderate protein diet developed in the 1920s specifically for the treatment of epilepsy. Results in the body using fat instead of carbs as an energy source. There are three main types of ketone bodies: beta-hydroxybutyrate, acetoacetate, and acetone. And these are measurable in blood, breath, and urine. This diet mimics the fasting state. Most people lose weight on this diet, but you can actually maintain your weight or gain weight. And that's particularly important for children who are doing this diet. So one of the big points I want to make is that there are different, when you say ketogenic diet, a lot of people think, oh, I know what that is. But in reality, it's a lot of different things. And I want to stress that. So the classic ketogenic diet is a 4-to-1 or 3-to-1 ratio diet. What do I mean by that ratio? 4-to-1 ratio means 4 grams of fat for every 1 gram of everything else. That means about 90% of your calories are coming from fat, because fat has more calories than carbohydrates and protein. But there's fasting and intermittent fasting that can produce a state of ketosis. There's the MCT ketogenic diet, where we might supplement the diet with medium chain triglycerides. There's the Atkins diet, LCHF, for weight loss. There's a modified Atkins diet. The modification is to add more fat. And this is actually an evidence-based treatment for epilepsy. There are calorie-restricted versions for cancer treatment, and many other kind of things. Lots of people out there who say they're experts in the ketogenic diet, and therefore they think they know how to cure cancer, they know how to cure schizophrenia. Please be skeptical of people who seem to know everything. So when I say a 4-to-1 ratio diet, most people have no idea what that means. And so I want to give a shout out to the Charlie Foundation for putting this slide together. So this slide contains 4 meals. They all contain the same ingredients and they all contain the same number of calories, but they are very different from each other. If you look at the green plate, this is what most people think of as a low carb or even ketogenic meal. It's a 1-to-1 ratio diet. You have chicken breast, broccoli, a ramekin of mayonnaise, and some olive oil. If you look at the red plate, this is what the 4-to-1 ratio diet looks like. You've got a paltry serving of chicken breast and broccoli, and you've got a lot of mayonnaise and a syringe of olive oil. What else can you eat? That doesn't look very appetizing. Well, the ketogenic diet can actually be quite appetizing, even a 4-to-1 ratio diet. You can have steak, salmon, coconut, butter. You can have bulletproof coffee, eggs and bacon. You can have low carbohydrate vegetables. You can have high fat fruits like avocados. You can get creative and make a keto pizza. You can make keto ice cream. So let me tell you about the ketogenic diet for epilepsy. So this story really begins with the observation that fasting can stop seizures. And this has been known since the time of Hippocrates. It was largely thought to be religious folklore, though. And in 1921, Dr. Raoul Galen reported the use of intermittent fasting to treat a child with epilepsy. The problem with fasting is that once people start eating again, the seizures usually come back. So it was the ingenious Dr. Russell Wilder at the Mayo Clinic who developed the ketogenic diet. And he developed it for one and only one reason. He didn't develop it for a weight loss diet. He developed it to stop seizures. And he was trying to mimic the fasting state. And that's precisely what he did. Early results were impressive. 50% seizure freedom rates, another 35% were markedly improved. But by 1950, this fell out of favor because anti-seizure medications were becoming more abundant, and it's a lot easier to take a medication than do this diet. It was rediscovered in the 1970s at Johns Hopkins because, lo and behold, 30% of patients with epilepsy don't respond to medications. We now have over, I've got on this slide 100, but I think it's actually more like 500 ketogenic diet centers around the world. We have 2 Cochrane reviews now. The most recent was in 2020, 13 randomized controlled trials and over 900 participants. At 3 months, seizure freedom rates in children are as high as 55%. But this study found that no adults achieved seizure freedom in the clinical trials. At 3 months in children, up to 85% had a 50% or greater reduction in seizures, but the results were less impressive in adults. The modified Atkins diet doesn't seem to be as effective as the 4-to-1 ratio diet. In some studies of all comers looking at the ketogenic diet to treat their epilepsy, at 1 year, about 55% remain on the diet, 45% discontinue it because it either doesn't work or they can't do the diet. So how does this diet work? What is it doing to the body that results in it stopping seizures? The reality is we actually know more about this diet and its effects on the brain than we do any other dietary intervention. That includes Mediterranean diet, omega-3 fatty acids, vitamin D, take your pick. We know more about the ketogenic diet than we do any dietary intervention in terms of its effects on the brain. Why is that so? Because this, for 100 years, has been an evidence-based treatment for epilepsy, and researchers have been studying it up and down, trying to figure out what on earth is this diet doing? How is it stopping seizures? Now, I'm not going to go through a complicated graph like this. Instead, I've distilled it into easy to understand bullets, but please understand, I did not make these bullets up. I'm not just pulling these out of thin air. These are all supported by a robust medical and neuroscience literature. So the ketogenic diet lowers blood sugar and insulin levels. Most of you probably know those are good things. It produces ketone bodies, which are an alternate source of fuel for especially to insulin-resistant brain cells. Ketone bodies themselves have anti-seizure effects. This diet changes neurotransmitter systems as well as ion channel regulation. So it changes calcium management or calcium regulation. It increases mitochondrial function and production. It decreases circulating polyunsaturated fatty acids, which are thought to be neuroprotective. It sensitizes the leptin system, so people feel full on this diet. Decreases inflammation. It changes the gut microbiome. Some researchers think that's actually the primary mechanism of action. This changes your gene expression and DNA methylation, increases autophagy, increases levels of NAD, activates sirtuin genes. All of these things are thought to have very powerful healing and anti-aging benefits. So what else is this diet being looked at for? Now here's a laundry list of different conditions that this diet has. This is documented in the medical literature with at least case reports, if not small clinical trials, if not large randomized controlled trials, like for weight loss or obesity. We have an abundance of randomized controlled trials for weight loss and obesity. But I don't want you to come away from this slide thinking that the ketogenic diet is a miracle cure for all of these conditions, because it is not. In many of these studies, it resulted in some benefits of some symptoms, but not others. And the illnesses often still continued and or progressed, but maybe progressed at a slower rate, or we just don't even have data on what it does to the long-term course of some of these illnesses. But I'll walk you through some of these examples. So let's talk about Alzheimer's disease. So what causes Alzheimer's disease? The predominant answer right now from the medical community is no one knows for sure. We know it involves plaques and tangles in the brain, but what causes those to accumulate? No one knows. Why are they even there? No one knows. But we know risk factors for Alzheimer's disease. And interestingly, they include a lot of metabolic parameters. They include things like diabetes, obesity, and midlife, cardiovascular disease or cardiovascular risk factors, the lack of exercise, poor sleep. Depression is a risk factor. People with depression twice as likely to develop Alzheimer's disease. The ApoE4 allele. What does ApoE do? It is related to fat and cholesterol transport and metabolism. Mitochondrial dysfunction has been shown in Alzheimer's disease, and brain glucose dysregulation has also been demonstrated, so that some people are calling this type 3 diabetes or diabetes in the brain. Do we have any evidence that the ketogenic diet can be an effective treatment? We have several animal models showing some benefits in terms of biomarkers of Alzheimer's disease. We have a small study of 152 patients with Alzheimer's disease given a ketogenic agent or a placebo. They remained on a normal diet, and the researchers found that the ketogenic agent seemed to improve cognition, but only in those who did not have the ApoE4 allele. There was a small randomized controlled trial of 23 people who were randomized to a low carb or a high carb diet. The low carb diet had memory improvement, and it was actually the level of ketosis that was the only metric that resulted in or was correlated with the improvement in memory. It didn't matter if the patients lost weight, didn't matter if insulin levels changed, didn't matter how many calories they were consuming. So we've got this trial from Johns Hopkins in 2019. But you know, this trial kind of is a testament to some of the challenges in our field. So these researchers spent 2.5 years trying to recruit 60 patients to complete this diet. They screened over 1,300 people. They only got 27 of those people to enroll, and only 14 completed the study. Nonetheless, they did find that patients who completed the trial, if they were able to achieve ketosis, they had improvement in memory. But this study really tells the medical community that it's almost impossible to get people to do this diet, and it's probably not worth anyone's time or effort, unfortunately. This next study was better. These researchers had better luck. They got 20 participants. They had very high compliance rates, 90 to 95%. And they assigned people to both a period of time on the ketogenic diet and a period of time on the American Heart Association diet. And the biomarkers of Alzheimer's disease only improved when the patients were on the ketogenic diet. The American Heart Association diet did not do that. The best study that we have to date was published in 2021. 26 patients randomized to 12 weeks of the ketogenic diet, a washout period, and then 12 weeks of the low-fat diet. And in fact, the patients assigned to the ketogenic diet had improvement in activities of daily living, quality of life, and they also had improvement in cognition, but it did not, that part did not reach statistical significance. The other two did, but with a larger sample size, we might get more robust findings. I just want to throw out a caution. Alzheimer's disease is associated with neuronal atrophy and cell death. Brain cells are dying. And once brain cells die, we are not resurrecting them. Not even the ketogenic diet can resurrect brain cells. So there may in fact be a point in Alzheimer's disease beyond which it's too late to intervene. So now let's talk about mental disorders. Why consider the ketogenic diet? Well, this is an evidence-based treatment for epilepsy. Many of its known mechanisms of action address problems, known problems in terms of the neuroscience in people with mental disorders. Many treatments for epilepsy are commonly used in the treatment of psychiatric disorders. Some of them are FDA approved, like Depakote, Lamictal, Tegretol, but many of them we use off-label. We commonly use off-label treatments in psychiatry because many of our standard treatments don't work. And in fact, there are a lot of DSM diagnoses that we don't even have any FDA approved treatments. Therefore, it's not unreasonable to consider this. Do we have any evidence that it works? For depression, there is at least one clinical trial wrapping up. There's another clinical trial hopefully getting underway within the next year. But what we do have is we have signals from research studies that have been done in other populations. So epilepsy patients or weight loss patients. And the ketogenic diet has been associated in some of those studies to reduce depressive symptoms. The confounding issue in that, though, is that if the ketogenic diet helps somebody have less seizures, people are going to say, well, of course they're not. Of course they're feeling better, or of course they're going to be less depressed. They're not seizing anymore. Even for a weight loss diet, if people are losing weight successfully, well, of course they're feeling better. Why wouldn't they? I want to talk about alcohol use disorder because this study was done by the National Institute of Health here in the United States. Turns out that alcohol use disorder is associated with brain glucose hypometabolism. So that's actually the same finding that we see in Alzheimer's disease, interestingly, but this is affecting different brain regions. Animal models have demonstrated reduced alcohol intake in rats on a ketogenic diet. But the researchers did a randomized controlled trial in alcoholics. They admitted them to an inpatient detox unit. Half the people got the ketogenic diet, half the people got the standard American diet, and they detoxed them by standard protocols. The people who got the ketogenic diet required fewer benzodiazepines for their detox. Nonetheless, they had fewer withdrawal symptoms. They reported fewer cravings for alcohol. And the researchers did brain scans on these people and found that their brain metabolism improved and their levels of brain inflammation decreased with the ketogenic diet. Let's talk about schizophrenia and bipolar disorder. For those of you who don't know, schizophrenia affects about 1% of the population, bipolar disorder, 2 to 5% of the population. For those of you who don't know, there's a lot of overlap in symptoms and these diagnostic constructs, and many people nowadays are thinking about these as a spectrum disorder. They are likely not unique disorders. And the reality is our current treatment outcomes are abysmal. In this 3-year observational study of over 6,000 people with schizophrenia, only 33% achieved symptomatic remission. Only a quarter reported an adequate quality of life, not even a good quality of life, just an adequate quality of life. Only 13% were able to work or go to school. And if you put all 3 of those together and call that a recovery, only 4% of people with schizophrenia using current treatments get a recovery. We clearly need better answers and ideas for how to treat these conditions. So does the ketogenic diet possibly play a role? We now have several animal studies published in pretty high impact neuroscience and psychiatry journals documenting that the ketogenic diet has the same effects as antipsychotic medications in these animal models of schizophrenia. The human data go all the way back to 1965, a pilot study of 10 women with schizophrenia. The researchers found that the ketogenic diet improved symptoms of schizophrenia. This was a very poorly done study, but a lot of psychiatry studies done in the 1960s were poorly done. So, I don't want you to draw too heavily upon this, but it was a signal at least. So we've got other research trials, other studies in bipolar disorder, schizophrenia, I and some collaborators have published 3 case series, and or the middle one was actually a controlled trial in Ecuador on 2 patients with schizophrenia. But instead of going through the details of all of these case reports and studies, I just want to tell you the story of one woman. And this is not her real picture, but I am allowed to use her real name, and her real name is Doris. So Doris was 70 years old when she started the ketogenic diet. At that point in her life, she had a 53-year history of crippling, excruciating schizophrenia. She was diagnosed when she was 17. She heard voices, she had delusions every day of her life, pretty much. She was tormented by her illness, was very suicidal, had been in and out of hospitals in the 2 years prior to starting the diet because of suicide attempts. She had gained a tremendous amount of weight. She weighed about 330 pounds, and she had a guardian. By every definition of schizophrenia, she had schizophrenia. She went to Dr. Eric Westman's weight loss clinic, and he was using the ketogenic diet. She tried it and was successful, started losing weight. The reports are within 8 days. She noticed that her hallucinations were going away or gone. Within several months, she managed to get off all psychiatric medications, and all of her symptoms went into complete remission. She lived until January of 2022, so about 14, 15 years later. She lived off of medications, completely symptom-free. She lost 150 pounds and kept it off. Very sadly, I just learned that Doris passed away from COVID pneumonia in January 2022. So what if you want to implement the ketogenic diet for mental illness? First and foremost, patients, please do not do this on your own. There are risks in people with serious mental illness. So if you just want to lose weight, go for it. I'm not here to naysay you. If you have diabetes and are on medications for diabetes, I'm really going to encourage you to work with your healthcare provider on that, because those medications are going to need to be rapidly adjusted. And it could be dangerous if you become hypoglycemic. So lowering your blood sugars is great. Lowering your blood sugars really fast is even greater, but it needs to be managed in a safe way. And the medications that you might be taking can make it somewhat dangerous. So it's not that the ketogenic diet is dangerous, it's that the medications that you're taking in conjunction with the ketogenic diet can be a dangerous combination, because the ketogenic diet is an extraordinarily powerful and effective intervention. Likewise, for people with serious mental illness, I have sometimes seen dangerous symptoms in the first week or two, and it is really during this keto adaptation phase, as people are withdrawing from carbohydrates, trying to adapt to burning fat as a fuel source. I've seen people develop insomnia. I've seen depression and suicidality actually get worse before they get better. I've seen people get manic and even more psychotic, especially from the insomnia. So these things need to be managed. They don't make me stop the diet, but they need to be managed in a safe way. And I help patients through these symptoms and through these phases. If the symptoms are really getting out of control, I will sometimes use extra medication to manage those symptoms. And occasionally I will have patients stop the diet because the symptoms are getting dangerous. Psychiatric medications can interfere with this diet, especially antipsychotic medications, which increase glucose, increase insulin, so they can interfere with the effects of the diet. So those might need to be managed or adjusted. And the fact is that treatment for serious mental disorders requires more than just the diet. It's not like the diet is going to 100% fix everything that ails you. People might need to have meds managed. They still need to sleep. They need a daily routine. You might want to add exercise to this treatment. You might need psychotherapy or stress management. If you're using drugs and alcohol, those aren't going to be helping any. So all of these things need to be considered and managed in a comprehensive treatment plan. So what do you need if you want to implement this treatment in a healthcare practice? I would argue that you need a competent mental health professional. Why? Because these are serious mental health disorders. So you need somebody who knows about those and knows what they're doing. And you need a competent ketogenic diet clinician who knows what they're doing. This could be a dietitian, it could be a physician, a nurse, it could be a lot of different people, a health and wellness coach, potentially. And it could be one and the same. You could have a psychiatrist or a nurse practitioner who also knows how to do the ketogenic diet. And maybe that person is one and the same. But I think you need those two things. You're going to need medical record documentation. And then the options are a keto coach or a keto food service. So medical record documentation, I'm not going to roll through this whole thing, but I do want to stress, if you're a medical professional and you're using this in patients, I really want you to be careful and document in the medical chart why you are using this intervention. Document that you've informed the patient of additional treatment options. The patient wants this as their treatment option. It is an evidence-based treatment for epilepsy. You're using it in an off-label way for their treatment-resistant disorder. You've warned them of risks. The most important risk that I really want to just let people know you should warn patients of, it's not so much the risk of starting the diet in the adaptation phase, although I think you should warn patients of that and be ready to manage that. The bigger risk is when patients actually do shockingly well with this diet, and then 4 months later, think to themselves, I'm cured. I don't need this diet anymore. My symptoms are completely gone. I'm all set. And they go off the diet. I just want to warn you, that's when all hell can break loose. And patients can get extraordinarily ill, psychotic, depressed, suicidal when they go off the diet, if the diet was highly effective. So you need to warn patients of that and document that in the chart, so that if 4 months from the time you start the treatment, the patient ends up in the hospital, you have made a paper trail about why, that you warn the patient, do not stop this diet abruptly. They went ahead and did it anyway, and now they are suffering. Because otherwise, the people in the hospital are going to blame you, the clinician. You clearly started this dangerous ketogenic diet, and look how ill the patient is now. But it would be like if the patient did really well on a medication, like clozapine or some other antipsychotic, and then they just abruptly stopped it. Clinicians should not be blamed for that. But again, we have to document. The future of this field is bright. There are at least 5 clinical trials of ketogenic diet for bipolar disorder and or schizophrenia that I am aware of throughout the world being conducted now. We also have a couple of trials, as I've mentioned, with major depression. I'm hoping the NIH is going to pursue more trials with alcoholism. We've got several trials looking at ketogenic diet for Alzheimer's disease. So the future is bright. And I just want to put in a quick plug for what is going to be coming out later this year, the brain energy theory of mental illness. So I am going to be audaciously proposing the metabolic and mitochondrial theory of mental illness that I sincerely hope has the potential to transform the mental health field. And with that, I thank you.